Pulmonary tuberculosis, TB, remains one of the major diseases of childhood. After a period of reduced incidence, now incidence is increasing. 60% of cases in childhood are in infants and the children less than 5 years, unfortunately. And there is another peak of tuberculosis infection in late childhood and adolescence. Causative organism is Mycobacterium tuberculosis. This acid-fast bacilli. So it's airborne infection with mucus droplets is the source of infection, usually coming from an adult with open pulmonary TB. Children with TB usually not infectious, okay? While adults with open pulmonary TB who are discharging bacilli in their droplets are infectious to others, and so you may consider a mother with tuberculosis with her baby. When we get infected with TB, we have either tuberculosis infection or tuberculosis disease. Usually having sufficient immune response or good immune response, this limits spread of infection, and disease bacilli become encircled, okay, by fibrous tissue, giving the radiological finding of John focus in otherwise well person. The whole tuberculosis infection can pass unnoticed in an individual with good immune response. Most of TB presenting in children is primary rather than a reactivation of a latent disease that usually present in adults. What's a tuberculosis infection? When someone got infected with the bacilli, we have the primary complex. The primary complex of what? Of local reaction in the lung that can be encountered or not, plus hilar lymphadenopathy. This is characteristic for tuberculosis infection. This is often asymptomatic, passed unnoticed. Tuberculin sensitivity develop over 3 to 12 weeks. So after an individual got infected with bacilli, someone has history of contact with someone, doing a tuberculin test should be delayed to 3 to 12 weeks to develop tuberculin sensitivity as a matter of type 4 hypersensitivity reaction. Mostly a normal X-ray is found. So what is a tuberculosis disease? When we have hematogenous spread of these bacilli, when immune system fail to enclose these bacilli and prevent its spread, this is a disease which is less common. Miliary TB can result where we have tubercle bacilli all over the body, presenting as diffuse infiltration of the lung, maybe TB meningitis, TB, any other organ in the body. Okay, so this can occur in up to 2% of cases only. Pulmonary disease of TB, okay, can usually present in the form of consolidation and collapse as a matter of pneumonia like this. Okay, so we have just a homogeneous obesity. This can be any form of pneumonia, but maybe having a contact history with a TB case, or maybe in a rehabilitated child, in a child with severe immune deficiency, in a child with AIDS, HIV/AIDS, so TB would be suspected. Lab work would be done and discover that the cause for this pneumonia is TB. Okay, cervical lymphadenopathy can be also present. So on suspicion, we should have high index of suspicion for tuberculosis infection. Tuberculin skin test, usually the first line test to be done. It will be positive in case of infection. Okay, but sensitivity develop after 3 to 12 weeks. This is the tuberculin sensitivity or Mantoux testing, which is intradermal injection of PPD or purine purified derivative, and then waiting or watching for an area of induration rather than just erythema. We measure an area of induration, which is a T-cell mediated reaction. It is a type 4 hypersensitivity reaction. This should be measured and examined after 2 to 3 days. Okay. So based on the child, if he is less or more than 4 years age, if he has or no risk factors like contact with a TB case, maybe like immune compromised condition. So having a child who is more than 4 years and has no risk factors, we need area of induration about 15 millimeter or 1.5 centimeters to diagnose TB infection. Okay, again, it is positive in case of TB infection, not necessarily TB disease. okay? 10 millimeter in a child who is less than 4 years and has risk factors, okay? So 10 millimeter sufficient. 5 millimeter would be considered positive in case of immune suppressed child or has history of TB contact. So just half centimeter or 5 millimeter tuberculin can diagnose the condition. Delayed response for about 12 weeks to the tuberculin testing, okay, can be after exposure to the infection, can be present in malnourished and immune compromised or young in children. So we start with the tuberculin scan testing, then look for chest X-ray findings. Positive findings in the chest X-ray plus positive tuberculin test usually diagnose the disease and warrant starting of antituberculous therapy. Hilar lymphadenopathy in the X-ray, so we may find pneumonia, for example, either in the form of diffuse bilateral bronchopneumonia in case of miliary TB, or can be lobar pneumonia. So pneumonia plus hilar lymphadenopathy like this, enlargement of lymph node at the hilum of the lungs, this is characteristic finding in case of tuberculous infection. I also finding segmental collapse and consolidation. So positive chest X-ray finding plus tuberculin scan testing is diagnostic. Interferon gamma testing or quantiferon gold is now a gold standard for diagnosis, which is a blood sample taken for measurement of interferon gamma as immune response to the tuberculous infection, usually combined with other clinical setting and the chest X-ray finding for diagnosis. About microbiology, to get the organism and try to identify its presence is often difficult in children because sputum is rarely available in children, young infant, and children swallow their sputum rather than spitting it out. And also, usually, children have a small amount of bacilli present in their sputum and secretion. So it's difficult to get a growth of tuberculous bacilli, and it is not a prerequisite for initiation of treatment with antituberculous therapy. Okay, so if we get a specimen either in the form of bronchoalveolar lavage, maybe in the form of a pleural fluid, nasogastric lavage, so we would search for the organism by Zell-Nielsen stain to detect the presence of acid-fast bacilli. Okay, this is diagnostic. Also culture, specific cultures for TB, waiting for about 6 weeks for its growth. PCR for TB also can be done on the specimen. Sometimes biopsy from lymph node or pleural fluid can reveal the typical caseating granuloma characteristic for TB. When a newborn is exposed to his mother with open pulmonary TB, he should start isoniazid prophylaxis, whatever the clinical setting, for 3 months if the mother has a confirmed disease. Usually, infant is and if the infant is asymptomatic and not showing any manifestations of tuberculous disease, so 3 months of isoniazid, after which a tuberculin test should be done. If it is negative, it should be repeated, okay, along with the interferon gamma blood test to confirm negativity and absence of tuberculous infection. If all negative, the interferon gamma and the other tuberculin testing, so prophylaxis stopped and the child considered free from infection. Now for congenital anomalies in the lungs, these include cystic adenomatoid malformation. So congenital anomalies in the lung can be discovered in an infant or a child presenting with recurrent admissions for pneumonia, for chest disease, for respiratory distress, maybe respiratory failure even. So finding in an X-ray this characteristic cystic lesions, followed by a CT scan to diagnose presence of these malformation. Sometimes it is asymptomatic, otherwise it can cause distress, so the treatment will be surgical. Another anomaly is a sequestered lung loop, okay, or lung sequestration, where we have a mass of non-functional lung. Okay, we have abnormal communication with airway and usually supplied by a systemic circulation. So having part of the lung or loop of the lungs that receive blood supply usually have a separate blood supply like that coming from the aorta, but has abnormal communication with airway, which means it's not aerated. This give us this sequestered loops that can present with recurrent infections and respiratory distress. Okay, also the treatment with is surgical by lobectomy. Bronchogenic cyst is another congenital anomaly of the lungs that can be complicated by recurrent infections, stridor if compressing the airway, lobar collapse if compressing the adjacent lung tissue, dysphagia if compressing the esophagus, and hemorrhage, okay, into the cyst. There is a question about the most common complication of a bronchogenic cyst. It would be the recurrent infections. Congenital lobar emphysema. Okay, emphysema means we have irreversible destruction of septi between alveoli, result in abnormal communication between alveoli that would disturb the alveolar function, disturb gas exchange. Okay, so having emphysema, by its name, it's lobar, so it affects one lobe of the lung. It is frequently asked question. Left upper lobe is the most common site for congenital lobar emphysema, followed by the right middle lobe, but lower and upper. Okay, so left upper is most common, followed by right middle and then right upper, while lower lobes of lungs rarely affected by emphysema, congenital lobar emphysema. For this, okay, if no respiratory distress, so the treatment will be conservative. Otherwise, if distress, so lobectomy is indicated also. Characteristically, in an X-ray, show the jet black opacity, jet black translucency due to presence of air in the emphysematous loop, and characteristically, this loop cross the midline, okay, like this, which would differentiate it from other anomalies. For example, diaphragmatic hernia, which cannot pass the midline. Scimitar syndrome. Okay, this is a scimitar. Okay, having hypoplasia in right lung due to anomalous pulmonary venous drainage, usually to IVC or right atrium. So when we have pulmonary vein that drains the upper right lung loop, okay, this pulmonary vein is draining abnormally into inferior vena cava or right atrium, appear like that, okay, as this whitish line, compress underlying lung tissue, resulting in pulmonary hypoplasia. And this can present with persistent chest symptoms, recurrent chest symptoms, or recurrent pneumonia. In the X-ray, it gives a characteristic scimitar sign. This is a rare condition, okay? So it can be asymptomatic or can present with recurrent infection, and the treatment also will be surgical. This is another X-ray showing the characteristic white line of pulmonary vein passing here, causing surrounded by consolidation. Diaphragmatic hernia or congenital diaphragmatic hernia, having the abdominal content passed through the weak diaphragmatic opening, okay, reaching the thorax. We are having intestinal loops in the thoracic cavity. Usually left side is the more common site. Having due to compression or pressure symptoms will be or pressure effect, we will have pulmonary hypoplasia on the contralateral, on the same side, okay, by pressure, and also on the contralateral side if we have a marked mediastinal shift. Usually there is antenatal diagnosis using the antenatal abdominal ultrasound, present at birth, okay, or can be delayed if it's mild, with manifestations of respiratory distress and scaphoid abdomen, okay, due to absence of the intestinal loop, and vomiting, okay, there is functional obstruction. Chest X-ray will show the bowel loops inside the thorax, very characteristic appearance, with differential diagnosis from cystic malformation, cystic adenomatoid malformation, and pneumothorax. Okay, it is essential in this condition to insert a nasogastric tube to deflate the stomach, okay, and reduce pressure effect on the compressed lungs. Okay, treatment logically is surgical, getting back the intestinal loops to the abdomen and correcting the diaphragmatic weakness or opening. So after surgical correction of the defect of diaphragmatic hernia, the pulmonary hypoplasia is the problem now, okay, and can present with chronic lung disease later on. So high frequency ventilation can help to recruit alveoli, okay, and treat the pulmonary hypoplasia. So frequently indicated in this condition after surgical correction of the defect. So long-standing hypoplasia and hypoxia will end by pulmonary hypertension, and ECMO, extracorporeal membrane oxygenation, may be required in case of failure of the conventional mechanical ventilation, failure of high-frequency ventilation. So ECMO is frequently indicated. Mortality post-surgical about 20 to 40%, which is high percentage, and the survivor may live with chronic lung disease. A genetic condition that is autosomal recessive in inheritance is the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a liver-derived antiprotease. Okay, it is antiprotease, so its absence will result in unopposed action of proteases that will result in proteolytic destruction of pulmonary tissue, okay, resulting in emphysema on exposure to oxidant. But this is usually rare or rarely present in children, usually present in adulthood with chronic lung disease and emphysema, and usually associated liver disease ending by liver cirrhosis. It is alpha-1 antitrypsin deficiency, one of differential diagnoses for chronic lung and liver disease. A severe condition also of lung called obliterative bronchiolitis. We have mentioned that bronchiolitis is very common and self-limiting condition in infancy period, caused mainly by respiratory syncytial virus. But other viruses like adenovirus can be complicated by severe disease called the obliterative bronchiolitis or bronchiolitis obliterans. Okay, so viral infection with adenovirus, sometimes mycoplasma, measles, or respiratory syncytial can end by bronchiolitis obliterans. This condition can follow lung or bone marrow transplantation as a complication, so can present in adults. We have severe disease that is diffuse, affecting small airways. Okay, we have severe diffuse small airway obstruction that will end by respiratory distress, dyspnea, wheeze due to bronchial obstruction, hypoxia due to the ventilation perfusion mismatch. Eventually, pulmonary hypertension will develop. Chest X-ray will show the hyperinflation, okay, with patchy atelectasis present due to the bronchial obstruction. CT would show the characteristic honeycomb appearance of bronchial pathology, and also these areas of hyperinflation are present due to the marked small airway obstruction. Earlier intervention with bronchodilators and steroids may give response, but usually this condition have a poor prognosis. Okay, hemosiderosis, also one of the chronic lung disease where we have repeated episodes of pulmonary hemorrhage with accumulation of hemosiderin at the level of alveoli. Okay, so hemorrhage can be symptomatic, having hemoptysis, which is cough with a blood-tinged sputum or with bleeding, coughing blood, okay, or can be silent, bleeding into the alveoli, presenting only with recurrent chest symptoms of unknown etiology, plus resistant iron deficiency anemia due to the long-standing blood loss. It can be idiopathic for unknown cause, having pulmonary hemosiderosis, or can be associated with cow milk protein insensitivity or cow milk protein allergy, where we have positive antibodies was suggested in a group of cases. Okay, some cases with cow milk protein allergy who were diagnosed with pulmonary hemosiderosis and undergone the restriction diet for cow milk and show improvement. So cow milk allergy presented as one cause for pulmonary hemosiderosis, but it can be idiopathic for unknown cause, or can be associated with Goodbusher syndrome, which one of the autoimmune condition having positive anti-glomerular basement membrane and anti-alveolar basement membrane, having antibodies combined against glomerular basement membrane, so presenting with glomerulonephritis that progress to end-stage renal disease in 50% of cases, and having antibodies against the alveolar basement membrane, presenting with pulmonary hemorrhage and hemoptysis and the pulmonary hemosiderosis. Other conditions associated with pulmonary hemosiderosis is mitral stenosis associated with chronic lung congestion, connective tissue disease related to pulmonary vasculitis, So presenting with episodic fever, dyspnea, wheeze, plus hemoptysis. Patchy shadowing will appear in the X-ray related to hemorrhage. Okay. Diagnosis usually will be a late diagnosis when we have recurrent chest symptom and hemoptysis, and then bronchoscopy is done with biopsy. Detection of hemosiderin-laden macrophages in the bronchoalveolar lavage will diagnose hemosiderosis, but will not diagnose the cause. We will search the cause later on. Management can be difficult in case of acute severe hemorrhage. Pulmonary hemorrhage will need treatment for the anemia, treatment for the hypoxia by respiratory support and anti-bleeding measures. Then long-term use with steroids and immune suppressor medications in case of autoimmune condition. About interstitial lung disease of childhood, okay, also can present as chronic lung disease and also can be a late diagnosis for a child with persistent chest manifestations and recurrent hospital admission. This is a rare condition where we have damage to alveolar units, okay, and damage to the bronchi. If we have the lung tissue is composed of alveoli lined by alveolar epithelium and related to the airways, and in between we have the interstitium containing the vasculature. So inflammation of this interstitial tissue would result in damage to alveoli and airways. Okay, so damage to alveolar units will result in failure of adequate gas exchange, presenting with respiratory symptoms of hypoxia and hypercapnia and so on. Or may have an underlying disease, may or may not having underlying disease for the interstitial disease. So hemosiderosis can present with interstitial lung disease, for example. Some rheumatologic condition, autoimmune condition can present like this. It can present in infancy with gradual progression of dry cough, dyspnea, wheeze, hypoxia, and clubbing as any chronic hypoxic condition. Older children may describe chest pain, reduced exercise tolerance, very important sign. Widespread crackles throughout both lung fields. So both wheezes due to bronchial pathology and crackles due to alveolar pathology will be present. We have mixture of symptoms and signs of alveolar and airway diseases. Signs of airway obstruction in the form of the barrel chest, apparent hepatomegaly due to depression of diaphragmatic copula. CT would show and X-ray would show the characteristic ground glass appearance or the diffuse reticulonodular infiltrates like this. Okay, this appearance would suggest we have interstitial lung disease. Would enter in a differential diagnosis with pneumonitis from opportunistic pathogen like pneumocystic gyrovece seen in immune-compromised patients like HIV, for example. So definitive diagnosis for interstitial lung disease, it would be late, it would be after open lung biopsy to find the microscopic changes of inflammation and up to fibrosis. Prognosis highly variable, can be good, can be very poor. Okay. Pulmonary hypertension, having increased pressure in the pulmonary circulation, can be primary, present as a congenital condition, which is very rare, okay, or can be secondary to underlying illness, either in the heart or in the lungs. So what are causes? Any chronic hypoxic condition. Hypoxia is associated with pulmonary vasoconstriction, and long-standing vasoconstriction will result in changes to the arterial walls, ending by masculinization and increasing the pressure in the pulmonary circulation. So in chronic lung disease, due to pulmonary hypoplasia, due to prematurity, whatever the cause, interstitial lung disease, obstructive sleep apnea, okay, and cystic fibrosis. So any chronic hypoxia will result in pulmonary hypertension, which can be reversible if the condition is treated early, but late intervention will result in permanent structural changes and progressive pulmonary hypertension, ending by poor pulmonary, right-sided heart failure, and the only treatment will be in the form of lung heart transplantation. Other cause for pulmonary hypertension is left to right shunting, congenital heart disease, long-standing pulmonary congestion. Left heart disease also related to long-standing pulmonary congestion, as in mitral stenosis, aortic mitral valve disease usually, or cardiomyopathy, and so on. So when to suspect that one patient has developed pulmonary hypertension, when having congenital heart disease, maybe when having chronic lung disease and the patient become more hypoxic and more dyspneic, okay, and more oxygen requirement is needed. When he have auscultatory findings of accentuated second heart sound and maybe murmur of pulmonary regurg and tricuspid regurg, having hypertrophy of the right side of the heart ending maybe by right side heart failure and the manifestations of systemic congestion. Okay, all these would suggest pulmonary hypertension. Also having shortness of breath, having increasing oxygen requirement and the syncopal attacks as pulmonary hypertension will result in reduction of output to the left ventricle and would be associated with reduction in the cardiac output, giving low cardiac output manifestations. Pulmonary hypertension can present in the neonatal period as a separate or isolated entity called the persistent fetal circulation, discussed in chapter of neonatology. So the use of pulmonary vasodilators, usually the treatment by high oxygen. Oxygen is pulmonary vasodilator. Nitric oxide, inhaled nitric oxide. Sildenafil, okay, is used as oral treatment for pulmonary hypertension. Prostacyclin is IV treatment, and nifedipine calcium channel blocker also can be used as a treatment. Here the characteristic congested pulmonary trunk, okay, related to the pulmonary hypertension seen in the X-ray.